Thank you, Professor Song. I'd like to congratulate first on very successful KOVAS 2025 meeting. And I am very honored and privileged to give a plenary lecture on the title of Effects of Exercise on Cardiac Function in Heart Failure with a Preserved Ejection Fraction. As I was introduced as on several commitment, but I'm still very excited about in the fields of heart failure, the preserved ejection fraction. And in this lecture, I'd like to share with you of my journey in this field for last 25 years. And I have nothing to disclose in this presentation. Heart failure with the preserved ejection fraction is actually quite common and also increasing. And if you look at this data about 20 years ago published in New England Journal of Medicine from Mayo Clinic, they look at the trends in prevalence and outcomes of heart failure with the preserved ejection fraction and also compare with the prevalence and outcome of reduced ejection fraction. And interestingly, the prevalence of reduced ejection fraction is rather decreasing. But in contrast, the prevalence of heart failure with the preserved ejection fraction is increasing. This is another study from Framingham. They also look at the epidemiology of heart failure. And they concluded that the profile of heart failure in the community has changed in recent decades with a lower prevalence of LV systolic dysfunction and an increased frequency of heart failure preserved ejection fraction, probably due to a concomitant risk factor trends. What about the incidence in Asian countries? This is data from Japan published in Circulation Journal about 10 years ago. They compare the heart failure the preserved ejection fraction defined by ejection fraction more than 50%. And when they look at the year between 2000 and 2005, the prevalence about 46%. But when they look at the prevalence of heart failure preserved ejection fraction from 2006 to 2015, it increased 63%. So more than half of heart failure, they have a preserved ejection fraction. But unfortunately, it is rather underdiagnosed or sometimes overdiagnosed. But more importantly, is underappreciated. Why heart failure with preserved ejection fraction is underappreciated? Probably because it is very complex and diverse pathophysiology. I'd like to more simplify the postulated mechanism of heart failure with preserved ejection fraction on the myocardium or ventricular side and also in the arterial side. Before I talk about the myocardial side and arterial side, I'd like to ask you, do you really think LV diastolic function is important in heart failure with preserved ejection fraction? The reason why I ask this question, I frequently encounter in a clinical situation, a patient with a heart failure, they have a normal ejection fraction, they usually excluded from the diagnosis of heart failure. So let me share with this 95-year-old gentleman with a severe dyspnea due to acute pulmonary edema. In fact, this gentleman was presented in our hospital 3 months ago. This is at the time of chest X-ray. This is a X-ray he presented with the severe dyspnea at the emergency room. As you can see, a significant change of pulmonary edema and pleural effusion. This very elderly gentleman presented with heart failure, pulmonary edema. And what do you think about the ejection fraction of this heart failure patient? Very old, elderly, severe heart failure. This is his echocardiogram, parasternal long axis view and short axis view. And the ejection fraction looks like about 70 to 75%. And also, if you think about this myocardial problem, when they exercise, their heart rate become faster. What will effects on LV diastolic function in patient with the heart failure to preserve the ejection fraction? And why is this important? This is the animation made by Professor Dae-Won from Seoul National University. It's, I think, most important animation that can understand why myocardial relaxation and LV diastolic dysfunction is important in the presence of faster heart rate. This is normal ventricle at the normal heart rate. This is abnormal myocardial relaxation at the normal heart rate. So if heart rate is normal, even though the myocardial relaxation is slow, there is plenty of time to filling the ventricle. But in the presence of tachycardia or faster heart rate, like exercise or atrial fibrillation with a rapid ventricular response, it's a normal myocardial relaxation. They can relax faster. But in the presence of significant delayed relaxation or myocardial relaxation abnormality, they do not have the ability to relax. And the time is short to fill the ventricle. The only way to fill the ventricle is increasing their filling pressure. There is a reason that the heart rate is very, very important in heart failure to preserve the ejection fraction. So if you think about the characteristics of patients with the early heart failure to preserve the ejection fraction, they develop increased LV filling pressure during exercise. And they have an increase in chamber stiffness. They don't have an ability to enhance myocardial relaxation during exercise. This is a very important study published in Circulation Heart Failure from Dr. Volok and colleagues, published in 2010. They measured the pulmonary capillary wedge pressure by invasive cardiac catheterization. And they compare with the control and heart failure to preserve the ejection fraction. As you can see at the baseline, even the diagnosis of heart failure to preserve the ejection fraction, their wedge pressure is normal and not much different from the control group. But interestingly, just elevation of their feet become different. But just 1 minute of exercise, the filling pressure increased to 25 millimeter mercury, and significant difference between the control group and heart failure to preserve the ejection fraction. The reason why I think this is very important study, not only the filling pressure at rest can be normal in heart failure to preserve the ejection fraction, but just 1 minute of exercise, it will change a dramatic difference between heart failure to preserve the ejection fraction and control. And second important characteristic is increase in chamber stiffness. This is a study that we published in Heart 2009. We developed a parameter representing a chamber stiffness, this diastolic elastance we call the ED. And we compare this parameter between two groups with control and heart failure to preserve the ejection fraction. As you can see at rest, there was no significant difference, but just only 3 minutes of exercise, the LV chamber stiffness become abnormal in heart failure to preserve the ejection fraction. And lastly, one of the important features of heart failure preserved ejection fraction is inability to enhance myocardial relaxation or suction during exercise. This is LV pressure tracing using digital pressure manometer. This is at rest and during exercise. If you look at the LV pressure tracing between two groups, there is no significant difference between these two groups. But when you look at this LV pressure tracing during exercise, as you can see, the minimal pressure, this is very important parameter feature of LV suction. This has become a little bit of a negative pressure. So during exercise, usually this suction become more prominent. But in the presence of myocardial problems, such as heart failure preserved ejection fraction, they cannot suck the blood at early diastole. This is represented in elevation of early diastolic minimal pressure, and also resultantly increase in LV-EDP. So if you have a chance to look at the LV pressure tracing, usually just only look at the LV-EDP. But in this LV pressure tracing, I think the minimal LV pressure is very important in the assessment of LV suction, and also pre-A pressure is very important, estimating LV filling pressure, and also LV-EDP is important, as you know already. So exercise can unmask or worsen diastolic functional abnormalities in patients with heart failure preserved ejection fraction, which is not usually evident at rest. I already mentioned about the characteristic of inability to enhance myocardial relaxation during exercise. How we can demonstrate this myocardial relaxation during exercise non-invasively? So we try to develop the concept of a diastolic function reserve, because mitral early diastolic annular velocity, E prime, is parameter reflecting myocardial relaxation. Therefore, the change of E prime with exercise will be a good parameter reflecting diastolic function reserve. This is our first study to look at change of E prime with exercise in patients with hypertrophic cardiomyopathy. We chose hypertrophic cardiomyopathy first because hypertrophic cardiomyopathy is a poster child of diastolic dysfunction. If you look at the E prime at rest, as you can expect, E prime is significantly lower in patients with hypertrophic cardiomyopathy. But when they exercise, E prime increased in control group. But if you look at the hypertrophic cardiomyopathy, the increment is quite blunted. And when we compare the magnitude of increment in E prime, the hypertrophic cardiomyopathy group is significantly lower when compared with the control group. The similar study that we undertook after hypertrophic cardiomyopathy is hypertension. Unlike hypertrophic cardiomyopathy, in patients with hypertension, at rest, E prime was not significantly different with the control. But during exercise, the response is quite similar to hypertrophic cardiomyopathy. Incremental E prime is rather blunted. And also, interestingly, patients with more myocardial fibrosis, they have a lesser degree of increment of E prime. And another study that we extended in the population of diabetes. Exactly the same response. At rest, no difference. But during exercise, in diabetes, myocardial relaxation augmentation is rather blunted. And the degree and magnitude of increment of E prime is significantly lower when compared to control group. So when we look at the diastolic functional reserve in various populations such as hypertrophic cardiomyopathy, hypertension, and diabetes, it is quite reduced. And we believe it is quite useful parameter in the assessment of myocardial relaxation reserve. Is there any prognostic impact of this diastolic functional reserve? Yes, we think they have a prognostic information. We extended our first study to look at the prognostic impact of LV diastolic functional reserve on clinical outcome in patients with type 2 diabetes. In patients who have a lesser degree of increment of E prime, they have a more dismal prognosis when compared with the better myocardial diastolic relaxation reserve. So I'd like to move on the arterial side. If you think about the classic patient of heart failure preserved ejection fraction, it's elderly female, history of hypertension, they usually have a very severe symptom. Why female is more prevalent in heart failure preserved ejection fraction? This study was published in JACC 2011 by Dr. Jiyoung Shim from our lab. And we try to look at the arterial stiffening and the LV diastolic function. Interestingly, when we separate men and women, the relationship between arterial stiffening defined by pulse pressure amplification and the E prime velocity. In men, there was no significant correlation between these two parameters. But in women, there was a very significant positive and negative correlation between arterial stiffening parameter and the myocardial relaxation. So we suggested that the effects of earlier wave reflection on central pressure may contribute to greater susceptibility to heart failure to preserve the ejection fraction, particularly in women. And also when we look at these changes in patients with diabetes, as I already showed before, this is a LV diastolic chamber stiffness parameter. The patient with diabetes and control, there are no significant difference at rest, but 50 watts of exercise, it became separated. But when we separate between diabetic men and diabetic women, compared with the diabetic men, in diabetic women, they have a lesser degree of stroke volume increment during exercise, but a similar degree of LV filling pressure elevation. So if you look at this relationship, LV diastolic elastance is abnormal during exercise, but not at rest, like here, in patients with diabetes without over heart disease. But interestingly, female gender was associated with the increased LV stiffness during exercise in patients with type 2 diabetes. So the female patients are very susceptible in heart failure to preserve the ejection fraction. What about the exercise effects on arterial stiffening? This is a study published in Hypertension 2008, Dr. Sung-Ah Park. And when we look at the arterial elastance in patients with hypertension at rest and during exercise, interestingly, arterial elastance was significantly better at rest. But during exercise, there is a crossover. The female patients, they have a very steep increase in arterial stiffening during exercise. And also the change or increment of arterial stiffness during exercise is significantly higher in female when compared with the male. So extracardiac abnormalities such as arterial stiffening significantly contribute to the development of heart failure preserved ejection fraction. And the female gender is quite susceptible in the development of heart failure preserved ejection fraction. And what's in the guideline? This is a European guideline published in European Heart Journal 2019. How to diagnose heart failure to preserve the ejection fraction. If you look at this guideline, if patient with a symptom, with a breathlessness, the clinical assessment, and standard diagnostic test, and we can do the heart failure HFpEF score, but if they have an intermediate, in fact, in our practice, a lot of patients fall in this category of intermediate heart failure score. And guidelines suggest that diastolic stress test should be performed either invasively or non-invasively. And if this diastolic stress test is abnormal, heart failure to preserve the ejection fraction is confirmed. This is another guideline published more recently in 2021, the European Heart Journal Cardiovascular Imaging. This is multimodality imaging in patients with heart failure to preserve the ejection fraction. This is an expert consensus document from European Association of Cardiovascular Imaging. In this guideline, I was invited as external reviewer, and I was quite fortunate to look at this guideline before it is released. And if you look at this guideline, for the diagnostic workup of heart failure to preserve the ejection fraction, using several diagnostic modalities, you need to estimate LV filling pressure. But if you have a normal LV filling pressure or non-conclusive study, you need to proceed with a diastolic stress test either by echo or cardiac catheterization. If elevated LV filling pressure at rest or during exercise, this will confirm the heart failure with the preserved ejection fraction diagnosis. This is a more recent review paper published in European Heart Journal Cardiovascular Imaging 2023. The title is Phenotyping Heart Failure by Echocardiography, Imaging of Ventricular Function and the Hemodynamics, not only at rest, but also during exercise. Why we are so importantly emphasizing the LV filling pressure? Because the several different aspects of diastolic dysfunction, their end results or compensatory result is elevation in LV filling pressure. So you need to pay more attention in LV filling pressure, not only at rest, but also during exercise. There is a reason that non-invasive diastolic stress test is very important, because we can estimate or measure LV filling pressure not only at rest but during exercise. And also you can do invasive diastolic stress test to get the same results invasively. So I'd like to conclude. Heart failure to preserve the ejection fraction is quite common and also increasing. However, importance of diastolic dysfunction is under-recognized or underappreciated. For the diagnosis of heart failure to preserve the ejection fraction, estimation of LV filling pressure is most important. But unfortunately, most of early heart failure to preserve the ejection fraction, they have a normal LV filling pressure at rest, but increase in LV filling pressure only during exercise. But in our routine practice, most of the diagnostic tests are performed at resting state only. Therefore, the diastolic stress test would be very useful to confirm the diagnosis of heart failure preserved ejection fraction, as multiple guidelines suggested. In addition, the extracardiac abnormalities such as arterial stiffening significantly contribute to the development of heart failure to preserved ejection fraction. and change of arterial stiffening during exercise, we should have more attention in those patients with heart failure preserved ejection fraction. Thank you very much for kind attention.